Hey y'all, it's Dr. Atkinson, and today we're diving into some of the key respiratory procedures nurses need to understand: bronchoscopy, thoracoscopy, thoracentesis, and the various types of lung and lymph node biopsies. These aren't just test questions. They're moments in real patient care that require your sharpest focus. Let's break them down together. Let's start with bronchoscopy. This is a procedure that allows direct visualization of the trachea and major bronchi using a bronchoscope, either flexible or rigid. It's used to inspect the airways, obtain tissue biopsies, remove mucus plugs or foreign bodies, and assist in diagnosing lung disease or infection. It's typically done under moderate sedation, though general anesthesia may be used in some cases. The flexible scope is the most common, especially in critical care, because it can navigate into smaller bronchi. Before the procedure, make sure your patient is NPO for at least 4 to 8 hours. That reduces the risk of aspiration. After bronchoscopy, here's your checklist. Assess respiratory status and oxygenation. Watch for bleeding, especially if a biopsy was taken. Make sure the gag reflex has returned before giving any food or fluids. Mild blood-tinged sputum may be expected, but persistent hemoptysis, increasing dyspnea, or chest pain should be reported immediately. Thoracoscopy. Next up, thoracoscopy, also called video-assisted thoracoscopic surgery, or VATS. This procedure involves inserting a scope into the pleural space through a small incision in the chest wall, usually under general anesthesia. It allows the provider to visually examine the lungs and pleura, aspirate fluid, take biopsies, and sometimes even resect small lesions. It's often used in diagnosing pleural effusions, pleural tumors, and for staging lung cancer. The scope gives us better access to the pleural cavity without doing a full thoracotomy, so it's less invasive and usually means a shorter hospital stay. Nursing priorities before thoracoscopy include making sure informed consent is signed, ensuring the patient is NPO, and completing your standard pre-op checklist. After the procedure, monitor vital signs, pain level, respiratory effort, the surgical site for bleeding or infection, and especially for signs of pneumothorax, like sudden shortness of breath. If a chest tube was placed, you'll be keeping a close eye on drainage, tubing, and air leaks. Now let's talk thoracentesis. This one shows up a lot on NCLEX and in real life. Thoracentesis is a procedure to remove fluid, or rarely air, from the pleural space. It can be done for both diagnostic and therapeutic purposes. What's it used for? A few things: to relieve dyspnea from pleural effusion, to collect pleural fluid for analysis, or to instill medication into the pleural space. You'll often hear the patient say they feel relief pretty quickly once fluid is removed, but there are risks. As the nurse, your job before the procedure is to explain what's happening, get consent, keep the patient NPO if ordered, and help position them, usually sitting upright, leaning over a bedside table to spread the ribs. After thoracentesis, watch for pneumothorax, sudden chest pain or SOB, monitor vital signs and oxygenation, check the site for bleeding, and assess breath sounds frequently. The fluid sent to the lab might be analyzed for everything from glucose and LDH to cancer markers and infections like tuberculosis. There are several ways to biopsy lung tissue, pleura, or lymph nodes. Let's go through each one. A pleural biopsy is done when there's fluid or inflammation in the pleural space, and we don't know why. It can be done with a needle, through a thoracoscope, or via open surgery. We use it to diagnose TB, fungal infections, and cancer. Lung biopsy. A lung biopsy is ordered when we suspect interstitial lung disease, cancer, infection, or sarcoidosis. There are 3 major methods that don't require surgery. 1. Transbronchial brushing. A flexible brush is passed through a bronchoscope to collect cells. 2. Transbronchial needle aspiration. A needle is used to pull up cells from deeper tissue. 3. Percutaneous needle biopsy, done through the chest wall under fluoroscopy or CT guidance. Possible complications of all these: pneumothorax, pulmonary hemorrhage, empyema. So close monitoring post-procedure is key. Lymph node biopsy. Now, let's look at lymph node biopsies, especially in the mediastinum. These help us figure out if disease like Hodgkin lymphoma, sarcoidosis, TB, or lung cancer has spread. There are 2 main methods. 1. Mediastinoscopy. A scope is inserted through a suprasternal incision to examine and biopsy the lymph nodes. No thoracotomy needed. 2. Mediastinotomy. A surgical incision is made near the second or third rib. It gives better access, but usually requires a chest tube afterward. Nursing care for all biopsies. Here's what we do after any respiratory biopsy. Monitor for bleeding, respiratory distress, and infection. Provide pain control. Educate the patient and family to watch for increased pain, SOB, redness or drainage from the site, fever or chills. Remember, patients are often anxious, both from the procedure and the potential diagnosis. Compassionate teaching and reassurance go a long way here. Recap. So to sum it all up, bronchoscopy, direct airway visualization. Thoracoscopy, VATS, minimally invasive lung and pleural inspection. Thoracentesis, fluid or air removal from the pleural space. Biopsies, sampling tissue from pleura, lungs, or lymph nodes for diagnosis. In every case, your nursing role is critical, before, during, and especially after the procedure. You are the eyes, ears, and advocate for your patient.